So now I would request Dr. Usha Ayagiri to make a formal introduction of Sarita Bajaj Madam. I know that it is very difficult to put her introduction into one slide, but then I will request Dr. Usha. Dr. Usha is a very good colleague of mine from Chennai, and she is senior consultant in diabetes, endocrinology and medicine from the Apollo Sugar Clinics and Apollo Specialty Hospital, Chennai. Then she has multiple publications and poster presentations to her credit. She's been principal investigator to multiple international trials in diabetes and endocrinology. So over to you, Dr. Usha, for formally introducing Dr. Sarita Bajaj, Madam, for the oration.
Thank you very much, Dr. Vaishali. As you said, on the one hand, we have Dr. Sarita, who requires no introduction at all to all of India. On the other hand, it is my deep honor to introduce Dr. Sarita, who is giving this year's Dr. Lokhandwala oration. Dr. Sarita is the Director Professor and Head of Medicine at MLN Medical College in Allahabad, India. She has several areas of interest that include diabetes, obesity, and growth. She is extensively awarded and has numerous orations and fellowships to her credit, including today's oration, and she's been awarded the Lifetime Achievement Award of the UP Diabetes Association. She's involved in several national diabetes projects as a lead, and we know she holds several posts across national and international societies. With specific relevance to today, we know that the entire spectrum of thyroid dysfunction, hypothyroidism, nodules, cancer, thyroiditis especially, is associated with a range of neurocognitive dysfunction, but there's a dearth of data about this particular state. Also, we lack any data about perhaps the benefits of yoga and especially the interactions between mind-body health and thyroid health in thyroid dysfunction as well as euthyroidism. As the current president of the Indian Thyroid Society, Dr. Sarita is leading the work in its field, and she's published on neurocognitive dysfunction in thyroid disease. So I'm going to hand over to Dr. Sarita. Dr. Sarita, it's indeed an honor to be able to introduce you. Thank you very much.
A very good morning to everyone. And it's a great privilege to be here, to be addressing the first Dr. Lokhandwala oration. I think we have the entire family with us today. And a greater privilege to have Vaishali honor me with this oration and to equate me with a person who was your mentor and who meant a lot to you, who has imbibed in you this concept of mind and body medicine. So I hope I'm able to, at least as a first oration, I'm able to give you some insights about thyroid and mind. So thank you very much. Regarding the current meeting, I think she's really done us all proud, because a number 500 is not a joke these days. It's really an achievement, Vaishali. Congratulations. And I think this, again, doing it both, I think that should be the trend for the future as well. So you have an opportunity to have a faculty of your choice, whether it's international or national. And of course, then the audience can get a wider exposure to the different concepts that people have. I think I would not be wrong, and I've told Vaishali this also, that I think we can call her the mother of mind and body medicine in India. And with her husband in the fray as the president of the society, so you have the mother and the father in one family and the progeny. I think it will be inbuilt. They don't have to worry about it, and they're becoming doctors, if I'm not wrong anyway. So one of them for sure. So I think I should start off with my oration now, and thank you all for the wonderful hospitality, especially Vaishali. And though it was tough getting here, but I think I'm happy to be here, because otherwise I really would have missed so much love and affection from all of you. Thank you very much. Usha, I think she must be around, I'm sure. Thank you for that kind introduction. And we had a lovely interaction while I was coming here as well.
Thank
So,
you very much.
so what I plan to do, like what the gist that Usha has given you, is, touch on all the aspects of thyroid, whether it is the development in the brain and the CNS, mechanisms of thyroid hormone action in the brain, the structural and functional alterations which are seen, then address mind hypothyroidism, all the disease entities which are there, then the elderly. I think there is a special focus or difference in thyroid and the elderly. When Vaishali asked me to talk about it, I said conventionally in an oration, one should have a little bit of their data, preferably, rather than just all theory. And luckily we'd already done some work on cognitive dysfunction in the elderly in subclinical hypothyroidism. So I'll touch upon that. It's not a big study, but nevertheless, I feel it's important as part of the oration. Then what are the sleep disturbances in patients with thyroid? Is there any role of brain imaging techniques? And of course, this is mind body medicine. So without talking about yoga, it would be incomplete. So this is how I plan to take it forward. So the as far as the brain and CNS development is concerned, the mechanisms which I'll be coming to are both genomic and non-genomic. The regulation of neuronal plasticity processes, stimulation of angiogenesis, neurogenesis, modulating the dynamics of the cytoskeletal elements, and intracellular transport processes as well. So we have, like I said, both genomic as well as non-genomic actions. Here the genomic actions are depicted and they are dependent on gene transcription mediated by its binding to the nuclear receptors and the formation of a heterodimer complex with the retinoid X receptor. This binds to the thyroid hormone receptor, which is located at the regulatory region of the T3 target genes. And the activity per se is regulated by an exchange of a co-repressor for a co-activator at the thyroid response element. This cartoon tries to show you the non-genomic actions that do not require the binding of thyroid hormone to the nuclear receptors. What are the structural and functional changes that we see? Now, this is during the stage of the development of the fetus. So these are the main neuronal features. You can have this is an outline of the hippocampal neuronal features. These are the structural alterations during development. You can have cell death, impaired growth of axons and dendrites, no alteration in the cell number, impaired dendritic arborization, and impaired cell migration as well. So the spectrum is very wide. And those of you who have seen a case of congenital hypothyroidism will know how devastating it is. My first exposure to this sort of devastation was when I was doing my DM at All India Institute. I mean, like, it's a very small world. We say that quite often, isn't it? So this child was from Allahabad. Can you imagine coming all the way to All India Institute for treatment? The daughter-in-law kept on saying to her mother-in-law, the mother of the child kept on saying to her mother-in-law that there's something wrong with my baby. And, if you're living in a joint family, then it's likely to be picked up, especially because you've had children before. As a first child, it might not be possible for you to realize that something's wrong. But the mother-in-law was not able to pick up. And they came with a TSH, a whopping TSH of more than 1,000. Can you imagine? I'm not sure if you've ever seen such big numbers. So this child was already 9 months old. And you can imagine the child comes to me occasionally every 3 or 4 years now, not very frequently. He's about almost 30 years old. So you can imagine that mental retardation never, ever goes away. Physically, he's a strapping young lad of about 5'10", and he looks very smart. But mentally, he will never recover. So this is the tragedy of congenital hypothyroidism. And these are the changes that I've just tried to highlight that can go wrong, and very, very desperately wrong. Again, I've just tried to list what is theory behind it as to what are the actual changes that take place in the hippocampus and the neocortex, and the underlying neonatal responsible for the neonatal cell death, reduction in the volume of the CA3 pyramidal cell layer, and all of them I have tried to list over here. So I'll start off with the most common thyroid disease, which is hypothyroidism. Yes, I'm sure everybody here has seen a case of hypothyroidism and managed them most effectively. So perhaps that is why alternative medicine has less role to play here, because hypothyroidism per se is so easy to treat, right? We just have one drug for that, and we have one drug for hyperthyroidism, isn't it? So these are the diseases which are so easy to treat, and perhaps that is why not the focus for alternative medicine. Very ancient, over a century old. But remember that patients with profound hypothyroidism can present with depressive psychosis, and symptoms of hypothyroidism mimic those of depression. As far as the relationship with mood and cognition goes, in most depressed subjects, the basal thyroid profile is within normal range. But those depressed patients who are analyzed for T3, T4, TSH, there is an increase in the total and free T4, but that regresses with treatment of the psychiatric disorder. You do not need to give any treatment for the thyroid. In other words, we can call it a acute thyroid syndrome, which is usually seen in ICU setting. So here, again, there is an abnormality, but it will revert not with thyroid hormone treatment, but with treatment for whatever the psychiatric condition the patient has presented with. So when you study depression further, a quarter of these patients have a blunted TSH response to TRH, seen more with unipolar as compared to bipolar depression. Again, so there is a considerable overlap between the clinical manifestations of mood disorders and those of hypothyroidism. I've just tried to list them all over here, and you can see a lot of them are common. Very interesting study, the Colorado Thyroid Disease Prevalence Study, which showed that many of the symptoms attributed to both hypothyroidism and depression, that is poor memory, slower thinking, tiredness, are seen in almost equal frequency when we compare them to non-depressed, even euthyroid controls. Who hasn't heard of myxedema madness? Yes, we do no longer. Fortunately, no longer do we see myxedema madness, nor do we frequently refer to it. But this was Asher who first described 14 hypothyroid patients, that is severe hypothyroidism presenting with melancholic depression. So manifestations of thought disorders vary considerably. They can include delusions of the paranoid, schizophrenic, or affective type. What is Capgras syndrome? Believing that one's spouse or a close family member has been replaced by an identical looking imposter. This is also seen and reported. Visual auditory hallucinations, perseveration, loose associations have been reported. And these may be preceded by symptoms of hypothyroidism months to years before the manifestation. That's also very interesting. It can present with acute psychosis. This is the term that we would now use. It may be missed specifically if there is no previous history of thyroid disease. So any patient coming to you for acute psychosis, screen for thyroid disorders, and in the absence of validated tools, given a wide range of presentations, it is easy to be missed. Remember, thyroid hormone replacement will relieve everything, all these manifestations, a little bit of antipsychotic therapy as support, which can later be discontinued. So there are other literature in this context as well. But again, like I said, we do not need to use this term at all. There was no clear-cut consensus, but 5 to 15% of hypothyroid patients may have some sort of psychosis. The bottom line here is that it is treatable, it is reversible, and if picked up in time, it will reduce hospitalization and then all the associated economic problems that would arise therein. Achievement of TSH level in the euthyroid range is adequate to assure restoration of both physical and neuropsychiatric function in adults. I've already told you, and if it's congenital, it is irreversible. In juvenile, yes, it is reversible, but there may be some compromise as far as the height is concerned, the stature is concerned, depending on how late you diagnose. The earlier you diagnose, the better the outcome, and that applies for most diseases, I'm sure that you are well versed with. Right. Something very interesting that is coming up these days. I don't know whether we will be able to use it, not use it. It will be available, that I can assure you. So I'm sure I have you guessing. Anybody can guess what I'm talking about? We talk of T4. What is levothyroxine? T4. What about T3? Why don't we use T3? Anybody? I'm not allowed to ask questions, and neither are you in a duration. But I thought, just to make it, just spice it up a little. Believe it or not, for 1 century, what was being used to treat thyroid? Of course, before I'm not talking very long ago. When we talk of insulin, again, it's a century just completed, right? But here it's a century and a half exactly since you're treating patients with hypothyroidism. Before that, what happened to them? They died. I'm sorry. Mortality was 100% if it's hypothyroidism. There's nothing else because we didn't have any treatment. So first it was desiccated thyroid extract, which was a combo of T4 and T3. But how much of each, we don't know. It depends on how the extract was made, etc., etc. I'm not going into the nitty-gritties of that. I think Vaishali can call me next time for a talk on. Okay, so for 1 century, we were using that crude extract, which was a combo of T4, T3. For the last, since 1970, for half a century, we are using only T4, that is levothyroxine, right? So this study is just what's trying to tell you, that patients on T4, euthyroid, are unhappy. They have, classical depression, which may be because they are not adequately, the tissues do not have enough T3. No, we are not talking of circulating T3. We are talking of tissue hypothyroidism because of inadequate T3. So do we need T3? Like I said, that's a whole talk in itself. So I'm just trying to make you interested. Yes, T3 is coming to India. Yes, we should be able to use it, but there are going to be a lot of discussion in that context subsequently. Fair enough? Okay, so I'll move on from there. So this was I think the last slide in the hypothyroidism part. What is the relevance of T3 in the management of hypothyroidism, right? So everybody is going to read a little bit today or maybe later sometime. So there are some vascular changes which have also been described. I'm not going into detail, but remember, if it's severe, prolonged hypothyroidism, again, some of it will be irreversible, short duration, newly diagnosed. Yes, it will be 100% reversible. But then, of course, elderly are a totally different ball game. Okay, coming to hyperthyroidism now. Again, these are the neuropsychiatric symptoms, a lot common. You can see so many yeses in mood and hyperthyroidism. Yes, about 50% of those yeses are common. Even subclinical, nervousness, irritability, they're more anxious as compared to euthyroid controls. Now here, this is a case report of a young male with a history of Graves' disease, poor medication adherence, who presented to the emergency department with psychotic features and hyperaccessibility, excessive agitation, paranoia, hyperactivity, and who was relieved with proper anti-thyroid medication. I'm not happy about the treatment part here, but then this is what they had given, and the patient responded. Again, the delay in the diagnosis of thyroid storm in patients with psychosis. Here we have two patients, a 63-year-old woman with bipolar disorder and a 37-year-old male with major depressive disorder. And psychosis in both these patients was well controlled with medication. Although they both showed symptoms of thyrotoxicosis, the symptoms were ignored because I told you there's a similarity between the presentation. So when there's a similarity between presentation, you would look more into what is disturbing the patient immediately, and what is the underlying disorder may get hidden. So if mental or physical state of patient with psychosis changes, then too thyroid hormone levels should be measured so the patient is managed effectively and in good time. What about iatrogenic hyperthyroidism? So there are drugs like amiodarone. Amiodarone causes both hypo and hyper. Iodine and lithium. Lithium is still an important drug in the psychiatric armamentarium. It is mainly associated with thyrostatic effects leading to goiter and clinical hypothyroidism. A lowering effect on the thyroid hormones by lithium has also been observed during lithium augmentation in patients with depression. Lithium exposure may also exacerbate pre-existing autoimmune thyroiditis. So there are several ways. And here you can see typically a patient with thyrotoxicosis after iodine contrast medium administration. I mentioned iodine, and here you can see mood swings up and down. And here this patient had rapid mood swings to mania, subsequent psychotic depression. And this patient was an underlying case of bipolar disorder who was being treated with lithium. What about thyroid cancer and the mind? Again, we have longitudinal study, this distress, anxiety, depression, and unmet needs in thyroid cancer survivors. So there is a tremendous emotional burden amongst overall cancer survivors, especially thyroid cancer. Distress, anxiety, depression, psychological concerns are still reported even many years after the end of treatment. A good relationship, alliance between patients and healthcare providers based on communication, trust, and support is important, and continuous medical and psychological surveillance are important to improve the overall well-being. Coming on to the elderly, adult onset hypothyroidism can affect the cognitive and emotional aspect as well. This is high among patients with hypothyroidism. It it increases with advancing age, duration of the disease, and the TSH levels. They're all statistically related. Several cognitive defects in intelligence, psychomotor speed, visual spatial skills, working and long-term memory have been observed, ranging from minimal to severe. Alzheimer's disease, 2 times more common. Motor skills, language, inhibitory efficiency, and sustained attention appear to be less impacted. Brain serotonin reduction and its precursor tryptophan are also affected by hypothyroidism. And remember that serotonin system is a pivotal part of the memory improvement and cognitive behavior enhancer. Perhaps that is the mechanism of hypothyroidism induced cognitive impairment. Again, the treatment will help you in overt hypothyroidism. There will be a clinically considerable reduction in affective and cognitive function. In subclinical, the treatment is more challenging because it is very subtle. It is very subtle, it may not be picked up, and therein lies the problem. So this is the study that I was alluding to, which has been published in the Indian Journal of Endocrinology and Metabolism. I just said that with subclinical hypothyroidism, there is less evidence and there is an unresolved issue, whether it is just because of age. In the elderly, there is likely to be a cognitive decline in the cognitive function per se. So is it because of the hypothyroidism? Is it because of the age? This is what we were trying to establish. So it was 103 patients, elderly, subclinical hypothyroidism, and we compared them with 103 age, sex, and education. See, whatever test that you apply for detection of cognition, the patient has to be reasonably well educated to understand what the patient needs to do. So the educational status is also of importance here. The clock drawing test is simple, but the Falstein mini mental examination needs a certain amount of literacy. So out of these 103 diagnosed subclinical hypothyroidism, about 31% had cognitive impairment compared to, so about half, so it's double as compared to the controls. As far as the cognitive impairment by the clock drawing test. So there are 2 tests that we were doing. One is the mini mentals test and the other is the clock drawing test. Again, it was 32, where it was present in about 25%. So here the difference was not so much. So clock drawing test is not so sensitive as compared to the mini mental state examination. So the difference in mean TSH between between patients with subclinical hypothyroidism with cognitive impairment was marginally different as compared to those without, but it was highly significant. So these were the baseline characteristics between the cases and control. They were all similar. If you look at the education status, like I said, that has to be comparable. So we made sure that is comparable between the 2 groups. But as far as the cognitive impairment is concerned, by the mini mental state, there was a significant difference between the cases and the controls, and the values also between the TSH are significantly different. Between cases and controls, as far as the clock drawing test is concerned, the difference was small but insignificant. This is a scatter diagram showing the relationship between the TSH and the mini mental state examination. We concluded in saying that prevalence of cognitive impairment was significantly higher in subclinical hypothyroidism as compared to controls. Remember, these are elderly subjects, and the presence of cognitive impairment correlated with the TSH. As TSH increased, the cognitive function declined. Again, there are several mechanisms possible mechanisms for cognitive impairment with subclinical hypothyroidism. Excessive circulating thyroid hormone resulting in neuronal loss, primary neurodegenerative causes. Subclinical hypothyroidism and low TSH are biomarkers for age and so are associated with other diseases of advancing age, including dementias. Even these patients would have a higher burden of comorbidity, and association may be due to non-thyroidal illness and drug effect on serum TSH. Elderly patients can have depression, lethargy, pseudo-dementia, apathy. Apathetic thyrotoxicosis, very easy to miss. And remember, reversible with treatment. Psychotic symptoms are rare. Severe hyperthyroidism may result in thyroid storm, which is a condition ranging from neuropsychiatric presentation, hyperirritability, anxiety, confusion, to apathy and coma. What about autoimmune thyroiditis? Yes, more in women. Most autoimmune diseases are more in women. Up to 20% of elderly women. Autoimmune diseases are associated with depression and anxiety, like it is highlighted in this study. What about dementia per se? Yes, there is a very, very strong association. Reduced TRH secretion, thyroid function shown to influence systemic oxidative stress. The higher the TSH, the greater the chances of dementia. And the mini mental state exam, which I just showed you, decreases with increasing age. All patients with cognitive dysfunction should be screened for dementia as well. What about sleep disorders? In hyperthyroidism, because of hyperkinetic features, can cause or worsen because patients are anxious, depressed. That can also impair sleep. Whereas in hypothyroidism, the quality of sleep is affected because of muscle pain, joint pain, cold intolerance, greater anxiety. That may also contribute to insomnia. Again, a very interesting study. Alterations in the hypothalamic pituitary adrenal thyroid axis and the gonadotropin releasing hormone in patients with primary insomnia. There was a direct correlation between the thyroid levels and severity of symptoms of insomnia. So the study also tries to highlight the relationship between subclinical hypothyroidism and poor sleep quality. Obstructive sleep apnea also associated, restless leg syndrome also part and parcel of both hypo and hyperthyroidism. Coming to the last part of my talk, that is yoga. I think I don't need to tell you how advantageous yoga is. You know, everybody knows what is Ayush. So I think, fortunately or unfortunately, allopathy has a lot of scientific literature to support it. So with Indian, like whether it's Ayurvedic, whether it's homeopathy, or whether it's yoga, still needs large scale randomized controlled trials. For diabetes, for metabolic conditions, yes, for a lot of diseases, it is coming up, for hypertension as well. So with lifestyle disorders, it is certainly coming into play, because like it's not a single asana that you need to do. You need to change your whole lifestyle or life set, whatever it is. So it's not just an asana or deep breathing that will help you. A whole lot goes into it. So all, I think, Indian pathies, or which homeopathy is of course practiced in several countries abroad. It has a German origin as well. So all these, unfortunately, are not backed by scientific data, isn't it? That is the only problem. Otherwise, I think there's a lot to be said about them. Yoga is safe. and effective intervention for several chronic health conditions, whether they are endocrine or psychiatric disorders. We know that levothyroxine per se will relieve the depressive symptoms. However, the risk of depression remains high compared to controls. So one was the T3 aspect, which I just told you. The other is the role of yoga. It has been shown to have a positive role in the effective management of depression in hypothyroidism per se. So here we have this. This is a pilot study. Women within the age of, I don't know why women are supposed to be more depressed than men. I think we need a study on that as well. That's not fair. Women within the age of 20 to 50 years diagnosed with hypothyroidism on T4, mild to moderate depression. They receive 60 minutes of yoga intervention every day for 3 months, 5 days in a week. And that was under the supervision of a trained yoga therapist. So you can see, as far as mental health, fatigue assessment is concerned, after 3 months, as well as mean change in the body mass index, lipid profile, and thyroxine dose, there was a significant difference. So an integrated approach, integrated yoga is useful for reducing depression in women who have persistent depression despite complete treatment of hypothyroidism. And these are the list of practices that were advocated by their professional yoga guides. I would like to summarize by saying that the interface between action of thyroid hormone and neuropsychiatric function is intricate. I've tried to show you the broad spectrum of action of thyroid hormones on the CNS with a wide array of clinical manifestations, whether it was hypo, hyper, overt, or subclinical thyroid cancer, thyroiditis. Thyroid disease-induced psychiatric disorders are largely reversible. I've addressed dementia and sleep disorders. And finally, I said that yoga may also be an effective intervention for the management of depression in hypothyroidism. Thank you. Thank you very much for this one.
Thank you very much, Dr. Sarita. That was indeed a tour de force. Questions are not customarily taken at the end of an oration, but I'd just like to quickly summarize. I think you've given us a masterly, comprehensive summary of all aspects of thyroid health and dysfunction and mind-body health, from the developmental aspects to aging, from covering the basic theory and pathology to the clinical implications and potential clinical actions that we can do to help these patients. You've talked to us extensively about the association and perhaps mimicry of psychiatric disorders, psychosis, and depression with the hypothyroidism, and the overlap of symptoms between hyperthyroidism, subclinical hyperthyroidism, depression, and other psychological dysfunction. You've also given us a masterly overview of cognitive dysfunction, especially with subclinical hyperthyroidism in the elderly. I think you gave us a little teaser about the potential role of tissue T3 and T3 as a therapeutic option in hypothyroidism. The most important thing for me was you've highlighted that the tools that you use to measure cognition and neurocognitive dysfunction are as important as the population that you're measuring them in. So it's not just thyroid and dysfunction, but what are the tools that you're using? And I really love the summary you gave us about yoga. I appreciate your point that for all of our therapies, the Indian native therapies, we need rigorous scientific clinical evidence, but I absolutely like the word that you use, that yoga is a safe treatment. So when we're ready to use so many treatments that potentially have side effects, I think adding in a safe therapy, if it has the potential to improve our patient's health with very little offset on the negative side, is absolutely to be promoted. I agree with you. So thank you very much for your time. Thank you very much for this absolutely enlightening and for me very educative lecture. Thank you, Dr. Sarita.
Thank you, Usha. Thank you. Excellent summary. Excellent summary.
Thank you.
Madam, definitely ovation. The way she has covered that topic so extensively. I think it was next time, madam, I'll have to keep a mind body medicine in thyroid conference, probably. Degree of magnitude of psychological involvement in thyroid is vast. And I think it's difficult to cover in half an hour. But we are so thankful to you for covering this in a short span of time. I would also request Dr. Chetan Deshmukh to felicitate Lokhandwala sir's family members for being here in this on the Sunday morning all throughout the way. Would anybody like to talk about Dr. Lokhandwala for 5 minutes? You want to spare some words or it's fine for you? Okay, thank you. We thank you all for being here today and accepting this invitation, and Madam for delivering the oration so effectively.